our treasurer, and Dr. Arun, the convener of our PG coordinator our PG program. Then seniors like Dr. Parvati Madam and today's expert Dr. Jathin and other seniors, my dear friends and dear students. At the outset, let me congratulate our team, PG Club, for regularly conducting webinars on each uh, Thursdays, which is very useful for PGs as well as for practicing pediatrics. And neonatology is very important for PGs and also for our day-to-day practice is very important. So today we are having Osce neonatology by Dr. So I wish all the very best for Arun.
Thank you, sir, for those wonderful words. Now I invite Dr. Jose O, sir, President NNF Kerala, to say a few words as well.
Thank you, Dr. Arun, and respected our dynamic. Take over, Arun.
Sir, break better. Video better.
Okay. Respected dynamic leader, Dr. Nandakumar, Dr. Gobi Mohan, Dr. Nihas, and all the PG coordinator, Dr. Mohandas sir, Dr. Arun, and all the members involved in the PG teaching programs. As Dr. Nandakumar mentioned, neonatology is one of the important DNB teaching program, DNG examination and MD examination. The neonatology is very core team for our examination part is concerned. I think the program today, the faculty, Dr. Jathin is there to enlightening regarding the different aspect of neonatology, OSCEs. I think this program is very much useful for not all PGs and practicing pediatrics, also very useful day-to-day practice. I wish you all the best. Over to Dr. Arun for further proceedings. Thank you.
Thank you, sir. So before we start, I would like to introduce our esteemed faculty, Dr. Jathin P, who was kind enough to volunteer for this program. So Jathin has started, like all of us, at Calicut Medical College, and then from there he went on to do his post-graduation from Trivandrum Medical College, and then he pursued his DM neonatology from JIPMA. And now after that he is actively involved in PG teaching as in workshops and during conferences, and he's currently a working consultant at Star Care Hospitals, although he'll probably will be moving soon from there so on to places, so which I would not reveal right now. But then thank you, Jathin, for being kind enough to accept the for being the expert for this program. And without further ado, I would hand it over to you.
Thank you, sir. Sir, am I audible, sir?
Yes, you are audible. Sharing, if you want to start sharing the screen. So for all the participants, I think you can ask your answer in the chat box, or if you would like, you can. It will be more interactive if you can answer with the through the mic and the video. And Jathin, you can probably give a little bit of space after each question so that you give them enough time to answer and then move on. If they're not, maybe move on with your answers as well and explanation.
Okay, sir.
Yeah,
It should be
because
wait for a volunteering, or should we
maybe
pick one
you
person
can
and
give them some time. Some of them are usually our PGs are very brave enough to answer,
yeah.
unlike
The
us.
problem is like sometimes I'll be picking the concern. I don't know, like the number only name will be there. So if I think
Some of them volunteer, some of them will volunteer. Yes.
okay. Okay.
Thank you.
So without
Over to you, Jathin.
further delay, we shall continue to the session. So I have compared like around 14, 15 questions, some sub questions in every question. So we'll try to cover most of them within. We are having next 1 hour, right, sir?
Yeah, yeah.
Okay. So going towards the first question. A 19 days old preterm baby, currently a post-menstrual age of 30 weeks for 2 days. The
Jathin, your
baby
screen is not. Your screen is coming
I'm
as a folder.
sharing. I'm actually sharing, sir.
Endado.
Only your folder is coming. What I can see is the Osce folder.
Store. 1 second, sir.
So in the share, I think you'll have to option for sharing the PowerPoint as well.
Okay. Sorry. Okay.
Yeah, now we
Now it
can
is
see.
visible, right?
Yes, yes.
Okay. So this was the question. 19-day-old preterm baby currently. Sorry. What is actually hiding? Okay. Currently it is 30 weeks, 2 days old, and the baby developed recurrent apneic episodes and feed intolerance. And the baby was found to be pale in examination and lethargic. The OG aspirate is brown color. So we have done the basic, some lab work of everything, X-ray was done, and this was the X-ray of the baby. So I will show the X-ray once again after some time. So my question is, what is the diagnosis based on the history and X-ray? If you're having a diagnosis, you can stage the illness. So anyone?
Some of them are
Sorry.
answering on the chat box, if you can see.
Chat box, I don't know where is.
So,
okay, chat. Sorry. NEC stage 1 is one answer. NEC alone is one answer. So clinical diagnosis will be NEC, right? Altered aspirate is there. There is systemic instability. Altered OG aspirate is there. But staging, is it stage 1? So what are the findings in the X-ray? Stage 2A. Okay. So I'll just let you know the answer now. You can see there are so many pneumatosis intestinalis visible here. The air within the bowel wall is visible here. So if it is there, it is usually stage A, right? But you can see some other here. You can you see the? Are you able to see the arrow here? This mouse pointer. If
yeah, they
you are
can see
able to see the arrow, yeah, you can see portal venous gas also in the liver shadow. So if the portal venous gas is also there, then it will be stage 2B. There is no definite pneumoperitoneum here. So it is stage 2B as per the X-ray and clinical scenario. So my next question will be, which is the single most important risk factor for this condition? And 2 other risk factors also. If you can unmute and that will be more helpful rather than chat box actually. So preterm, the prematurity is the most important risk factors for development of NEC. Other risk factors, formula feed, okay, sepsis, okay. Some other risk factors. So preterm babies or tame babies are there. Preterm babies risk factors like hypotension, instability, hemodynamic instability, PDA, polycythemia, all those things are termed, maybe asphyxia. So many risk factors are there. So what findings do you expect? We have done CBC, electrolytes in the question. We have done CBC, CRP, electrolytes, blood gas, etc. So what all findings you can get in NAC? So if somebody can answer, that will be easier for me actually. More of an interactive kind of.
Dr. Aparna, Dr. Maya, it'll be good if you all can actually speak up. Unmute yourself. Feel free to unmute yourself and speak up.
So these are basic questions only, right? So can someone answer?
Thrombocytopenia, sir.
So thrombocytopenia can be there. Then CBC showing
Acidosis.
and blood gas showing metabolic acidosis, thrombocytopenia, leukopenia, right? CRP will be
High.
CRP usually elevated, and electrolytes, will there be any change? So usually there is a something called a triad of biochemical triad in this thing, right? So hyponatremia, metabolic acidosis, and thrombocytopenia will be there. So just the last question, name for evidence-based interventions which can be used to prevent this condition. Someone, should I call the names?
You can actually, if.
Sorry. The problem is I am not sure whether it is consultant or not. That's why.
Dr. Aparna, Dr. Yadagiri, you all can.
The formula regime.
So
Strict feed
formula,
regime.
okay. Strict feed regime. So a proper feeding protocol is based on mother's human milk, right? Then what else?
Breast milk rather than formula feeds.
Yeah, like promoting breast milk. Then other evidence-based strategies. So there is a dose-dependent relationship with breast milk and NAC. So more breast milk will lead to lesser NAC. Then a strict feeding protocol also will help. Then what else? So these are the answers. So we have to increase the use of the human milk, and there should be a standard feeding protocol. And we can opt for measures which promote intestinal perfusion, like antenatal corticosteroids for mother, treatment of PDA if it is hemodynamically significant, delayed cord clamping, severe anemia should be prevented, etc. And we can promote healthy microbiota, like probiotics. WHO recommends use of probiotics in preterms, avoidance of H2 blockers, and the antibiotics. Long-term antibiotics also should be avoided. So these are the different evidence-based interventions to reduce the risk of NAC. Okay. So shall we go to the next question? One baby in postnatal ward, the resident has on examination noticed this finding. So what is the probable diagnosis? Can one spina bifida occulta? Okay. So you can see a tuft of hair over the lower back, which can be associated with the spina bifida occulta. So what other lesions in the same area may be associated with these findings, with this condition? What all other skin lesions can be indicative of spina bifida?
Sacral dimple. Coccygeal
Dimple,
pit.
sacral dimple. Coccygeal pit is more benign, right? It's near anal verge, anal opening. So, but if it is a sacral dimple, sacral, then it is more like the chance is more. Then what else? Hello.
Someone has mentioned swelling. Dr. Reshma has
Swelling,
mentioned
can you be
swelling.
more specific? There are so many kind of swellings. So I think we have got on.
Meningocele.
Yeah, meningocele is actually the finding, right? So we're actually having spina bifida here, and spina bifida occulta especially, there can be so many skin manifestations. Associated skin findings also might be there, which we will lead the suspicion of spina bifida occulta can happen because of that. So if such, which all findings, if it is there over the skin in the lower back area, we should suspect spina bifida occulta. That was the question. Hemangioma. Hemangiomas are there. Then lipoma, hemangioma. Just to show the answer then. Okay. Well, after the last question, I will show the answer. Which condition to be ruled out if the baby is having more severe form? So we have seen it is spina bifida occulta. So if there is a more severe form of the illness, this thing, then what additional defect we have to check for? Chiari, yeah. Arnold Chiari malformation, type 2 Chiari malformation, there can be myelomeningocele with the CNS malformation. Okay, the answer in these dermatological findings, we can actually classify it into high risk, intermediate risk, and low risk. The high risk findings include the tuft of hair, hemangioma, this sinus tract, lipoma, caudal appendage, etc. Like a acrochondron, a tail-like thing. Segmental hemangiomas, all these things are high risk. So, which antenatal medication can prevent the defect? I think you have seen the answer. So I will just modify the question. You have seen the answer, like folic acid will prevent the defect, right? So the dose is usually 400 microgram. So if already one sibling is having this neural tube defect, then in the next pregnancy, what advice you will give? Yeah, already someone has answered 4 mg. So 10 times the dose of the usual prophylaxis we have to give. 4 mg folic acid you have to give. And that too 1 month, at least 1 month prior to conception, and at least 3 months towards after the conception we have to give. Very good. So shall we move to the next question? So there is a ultrasound finding of one 28-week newborn baby who had a stormy newborn course in NICU during the first week of life. Baby is already few weeks over now, like 3 weeks of life now, and ultrasound cranium was done because anterior fontanella was found to be bulging, and there was increase in head circumference more than expected. So this was the finding of the ultrasound. So you are able to see the image, right? So there are two images, left-hand side and right-hand side. Just see the image for few seconds. Okay, my question is, what does the yellow line denote in the first figure? Can someone answer, please? The first figure, what does the yellow line denote? So that is a coronal section of the cranium, where you can see the ventricles. Yeah, it is a lateral ventricle, dilated lateral ventricle is there. What is the, yeah, it's called a Levin's index. Okay, so from the midline of the false cerebri towards the lateral most end of the lateral ventricle, if you measure, that is called Levin's index. You can see the another yellow line here. It is not a question, it's like additional question. What does that indicate? It is also, the measurement is also used for objective assessment of the hydrocephalus. Anterior horn width is different. Anterior horn width will come in this area. Is anterior horn is here, right? Anterior horn width is here. Yeah, thalamo-occipital distance. So this is the caudate part, and this is the thalamic nuclei, caudate and thalamus. And from the thalamic area, you are actually measuring towards the posterior end. So thalamo-occipital distance. So my question, when do you consider intervention based on the above measurement? That is Levin's index. We have measured Levin's index. There should be some utility for that measurement, right? So we have to intervene if the measurement is beyond certain point. So what is that point? What is that limit? Answer. If it is beyond dash centile, something like that. 97th centile. It has little bit extra, so it is 97th centile plus 4 millimeter. 8 mm. No, that it is based on the gestational age wise centile chart is there. I will show the chart in the next slide. So if it is more than 97th centile plus 4 millimeter, we can do the intervention. So can you name one temporary and one permanent CSF diversion? The intervention is CSF diversion. We have to reduce the hydrocephalus. We have to take out the fluid. So can you name one temporary and one permanent CSF diversion? One has mentioned VP shunt. Is it temporary or permanent? Yeah.
Temporary.
Temporary VP shunt we are actually using for a more long duration, right? It's more towards a permanent thing. Temporary, example. We can do
EVD.
LP, EVD, okay. EVD, okay. LP we can do. This anterior fontanella tapping we can do. Then the subgaleal shunt we can do. Those are usually considered as temporary measures. Permanent usually VP shunt, the other shunt towards other areas, etc., can be considered as long permanent. Or ventriculostomy is there, endoscopic third ventriculostomy, etc. is there. Acetazolamide usually it is not recommended in newborn. We usually do the CSA diversion techniques mainly. So these are the answers. Levin's index 97. Sorry, one more question, I think. Sorry. You have seen hydrocephalus here, right? So what may be the probable reason for hydrocephalus in this case? IVH you have mentioned. So what is the grade of IVH here? That's an additional question. Grade 1, grade 2, grade 3. Yeah, somebody has mentioned grade 3. So grade 3 means with ventricular dilatation, right? You are mentioning. There is ventricular dilatation, there is some IVH, but this is not a grade 3 IVH. This is actually a grade 4. No, actually, there is ventricular dilatation, but it is a complication of post hemorrhagic dilatation. It cannot be considered as grade 3 or grade 4. Okay, grade 3 means because of the volume of the blood itself, it has to be dilated. It has to distend the ventricles. You can see here, there is only a small amount of blood in the chorothalamic groove. So it's actually, I should not be asking the grade from this picture. That's the answer. It is post-hemorrhagic ventricular dilatation. It's a complication of the hemorrhage. Okay, you can see the chorothalamic groove and there is a bleed here. We have to, in the acute phase, we have to analyze and decide the grade. Okay, shall we move? Hope it is clear. Shall we move to the next question? This is the 97th centile. We have to be alert above this line. And if it is beyond 97 plus 4, then we have to intervene. Okay. Next question. A 1.8 kg male baby. The male baby born at 35 weeks. GDM mother brought to NICU from postnatal ward with complaints of poor feeding and lethargy. The blood glucose, when we tested, it was only 30 milligram per deciliter. But baby was not having any seizures and all. So what is the next immediate line of management? Can someone answer? It's a routine clinical scenario. Right? What is the next management? Late preterm baby, 1.8 kg. Baby having blood glucose of 30 milligram per deciliter. IV fluid, give feeds 2 ml per kg dextrose. So we are having, I think, almost all the treatment options we are having as answer. So the answer here is the baby is having 30 milligram per deciliter. And I have mentioned like there is no seizure, but what is there actually? There is poor feeding and lethargy. Okay. So it is actually a symptomatic hypoglycemia. So if there is asymptomatic hypoglycemia, or if the value is below 25, we can give a bolus, dextrose bolus, 2 ml per kg. If it is asymptomatic hypoglycemia, then we could have go for other things. Okay, so we are actually giving bolus here, written bolus. So what are the risk factors for hypoglycemia in this baby? You can see the description. Just tell me, enumerate the risk factors for hypoglycemia here.
Medium mother, preterm,
Yeah, GDM mother, preterm baby, late preterm baby. Then there is low birth weight also, right? 1.8 kg baby. So can you answer why GDM, IDM baby, like infant of diabetic mother, is having hypoglycemia? What is the reason for that? Just as it was as addition, just a question, discussion. So why GDM baby is having hypoglycemia? What is the reason? Increased insulin in secretion. Yeah, because mother is having hyperglycemia, baby will develop hyperglycemia. As a reaction, there will be more insulin secretion. So once the baby is out, the insulin level will remain higher for some time. So it will cause hypoglycemia. So if the baby was started on 80 ml per kg per day of dextrose D10, we have started the baby on IV fluids with a D10, 80 ml per kg per day. So what is the GAR it is going to provide? You are having mobile phones with you, right? Just calculate and tell me the GAR. 5.6. Yeah, it looks correct. Usually around 5.5 will be the. So the equation will be GAR is equal to percentage of dextrose into fluid requirement in the day by 144. By 144. Okay. So the last question, what is resistant hypoglycemia and what is persistent hypoglycemia? What is the definition for that? Resistant and persistent. Both of them look significant, right? So resistant and persistent. Can someone answer? Just guesswork also will be okay. GR12 some has mentioned. Is it resistant or persistent? Yeah, resistant hypoglycemia if the requirement is beyond GR12, like medications and all. So that is resistant. Persistent means it will be related to time, right? Persistent, persisting for some time. So beyond what period? 2 weeks is, I feel like, more prolonged. I think 1 week will be better. 72 hours is usually it is more than if it is persisting requirement, GR requirement more than 7 days. We can call it as persistent. Okay. So these are the answers. I have like I just wanted to discuss the GAR thing. Simple. I don't know. There are different methods available. So as it is PG discussion, so I would like to share the way I am actually calculating this thing. So if we are having certain ml per kg per day fluid requirement for the baby, and we have to calculate the dextrose percentage, right? Based on that, we have to prepare a solution which contains the asthmatic percentage of dextrose, and we will infuse based on the fluid input for the day. So if we want to prepare a 15% D15, how can we prepare? D15, there is no ready-made solution available. We are having 5, 10, 25, 50 and all are available. So 15 is not available. So if you want to prepare 15% dextrose, you can actually take a ratio like this. If you are preparing the solution with a D10 and D25, just subtract from the 15. Just take the difference from the 15. So from 15, the difference is here. 5 will come here. And here, 10 will come. Okay, just take the ratio. That is 10:5, which is 2:1. So if you take a solution in such a ratio, then the resultant dextrose concentration will be 15%. So if you want to prepare 50 ml solution, 50 into 2/3 will be the D10 portion. 50 into 1/3 will be D25 portion, and the mixture will be D15%. I hope you have understood. If you want to explain, I will just explain once again. With using this calculation, actually you will be able to prepare any amount of solution, and without having a means mathematical so many those issues won't be there. You can easily calculate and prepare the GIR. Can you just respond whether it's understood or not?
Understood.
Hello?
I think someone answered understood. I think Maya mentioned understood. Yeah.
Okay.
I think we can keep a screenshot or something of this if they want. This is a very good way of preparing fluids. Yeah. Fast enough.
So going to next step. So a term baby was born by emergency LSCS in view of placental abruption and fetal bradycardia. The baby required resuscitation. Chest compression was given for 10 minutes. And the baby developed seizures. Baby survived. Baby was shifted to an ICU. Baby developed seizures at 12 hours of age. So can someone tell me the sequence of initial steps of resuscitation as per the latest NRP guidelines, NRP algorithm? Answer. Initial steps.
Someone will have to answer on the mic if that's okay.
So based on NRP 8, it was drying, warmth, drying. Then NRP 8, warmth, drying, stimulation, positioning, suctioning, DSPS, like that I used to remember. That has changed. That's why I'm asking. So what is the current latest NRP 9 initial steps sequence? Dry, warm. Warm should come actually first. Warmth, dry, then what is the next sequence? Next step. No suction is also okay. That part comes at the end of the initial steps. So in between, what happens?
Code management.
Yeah, code manager initially we'll discuss, we'll decide. Then warmth, dry, then dry, stimulation, positioning, clearing the airway. Yeah. Dry, stimulation, positioning, and clearing the airway if required. Okay. So name the recently published RCT from low middle income countries related to birth asphyxia, which has got a significant effect on our routine care. A large trial from India, Bangladesh, and Sri Lanka. Yeah, Helix trial. Helix trial, and it has shown the mortality was more in the LMIC setup using therapeutic pooling. And can you name 4 complications of therapeutic hypothermia? Some common complications: cooling of the baby, sepsis, okay, more than sepsis, subcutaneous fat necrosis, good. Then what else? If you cool the baby beyond certain point, what will happen? Hypoglycemia. We are actually baby will be on IV fluids, less likely to cause hypoglycemia. Bradycardia.
Hypothermia followed by bradycardia.
Yeah, bradycardia, more like arrhythmias can happen. Okay. subcutaneous fat necrosis, coagulopathy, DIC can happen, thrombocytopenia. All those are the complications. And there is an image given in the next slide. Can you name the cooling systems, both of them?
Whole body cooling system.
Yeah, whole body. And some extra. What is the difference between left and right? Right is also whole body. Mira cradle is the right one. So what is the difference between left and right? What is the this image? What is this material? FS21 is written over it. What is that material? Ticothem Neo is Ticothem Neo is the left hand one. Both are whole body only. But what is this actually? It's a servo controlled cooling device, and that is the PCM, as someone mentioned, phase changing material. So both are. This is more like a economically more viable for low middle income countries, and this is more towards a higher price range is higher for this. So these changes I'm not going into detail. So there are so many changes in NRP 9, 8th and 9th edition, just to go through those. So helix trial, the complications. Okay. So next question. You are called to labor room due to a possible shoulder dystocia. Baby is vigorous and crying, and she's brought to the warmer soon after delivery. You palpated the clavicles and found there is no break in the bone. But however, she was found to have decreased movements of the right arm. You can see the image. You can see the asymmetry. The baby is not moving the right arm. So, which all nerve roots apply to form the brachial plexus? So there is probably brachial plexus injury. C5, C6 is only 2 roots, right? Is it that short? Yeah, C5 to T1 is the brachial plexus. Eps palsy, okay. C5 to T1 is the brachial plexus, and there is something called Eps point in the upper trunk, where if the damage happens, it will lead to Eps palsy. So, how to differentiate between Eps palsy and complete brachial plexus injury? Clinically, how can you differentiate it? Grasp, yeah.
Palmar grasp will be there.
Yeah, the finger movements of the finger. If it is intact, that means only is Eps palsy alone. And if that is also involved, then it is more severe and more complete brachial plexus injury. So, what are associated other complications to be looked for in this baby? So there is paucity of limb movements, some brachial plexus injury is there. Which all,
Clavicular fracture.
yeah, those other fractures and all are okay, related to the nerve injury.
Ptosis.
Oh, yeah, Horner syndrome, ptosis with the meiosis, right? And if it is C5 to T1, so if the sympathetic ganglia, autonomic ganglia is involved, then there can be Horner syndrome. And phrenic nerve palsy, diaphragmatic palsy. These babies will be having distress. They will think it is TTN. It may be phrenic palsy also. We have to be aware of that. So the recovery of the elbow function, if it recovers before certain age, is usually considered as a good prognosis. So what is that age? We have done physiotherapy and all, and 4 weeks, okay, a little bit more. Okay. The average textbook says 3 months. So if the function regains before 3 months itself, then it is considered as a good prognosis. I'll just show one image of this is the C5 to T1 nerve roots, finger flexion, phrenic injury, Horner syndrome, and 3 months. Okay, one I would like to show one video also. Are you able to appreciate? Sorry. So can someone tell what you're seeing here? Are you able to appreciate something here? There is some distress, right? CETH, we are actually discussing about Eps palsy. This is not the next question. Sorry. This is like a last additional question for the. So we are discussing about Erb's palsy. So are you able to appreciate there is asymmetry of chest movements here? Here actually you can see the retractions. Here that many retractions are not there. This is actually left-sided phrenic palsy. Usually in the X-ray, usually the left side of the heart will be on the low, little bit towards lower side. And if the baby is on CPAP, we may not be able to see the typical phrenic nerve. This thing. So this is actually a higher up phrenic nerve, like a diaphragm. And this was the clinical image, which is corresponding to having the phrenic nerve injury. Okay, next question. So this is one of my personal favorites. You can see one graph here. This is the antenatal fetal growth curve is given 1, 2, 3. So what is the most likely cause of fetal growth pattern in curve 3? All these three curves are actually abnormal. Abnormal means in the sense it is not okay. So what is the most likely cause of the fetal growth pattern in curve 3? Can someone answer this question? Answering will be easy to discuss. So if you answer. So just to see there is like a 10th centile, 50th centile, and 90th centile is here. And there are three curves are there. 1, 2, 3, curve 3. Uteroplacental insufficiency. Curve 3, okay. Genetic disease torch, okay. So basically, this chart explains the difference between IUGR and SGA. So SGA means small for gestational age. It is like at the time of birth, if the baby is below 10th centile, the baby is considered to be small for gestational age. The problem is the baby might not be having intrauterine growth restriction. That is what curve 3. It is SGA baby. It is below 10th centile, but the baby has gained weight along constantly in that centile line. So there is no retardation in growth, but the baby is SGA. Usually it happens, torch and all. What happens is there will be some growth restriction will be there definitely. So this is probably the constitutionally small baby, curve 3. What about curve 1 and curve 2? Curve 1, you can see the baby was normal near 90th centile or maybe 70th centile during the initial part. Then there was a growth faltering. But at the end, at 40 weeks of gestational age, the baby is still about 10 centile. So this is AGA baby, but this baby is intrauterine growth retarded. Okay, you can see the centile lines actually this faltering. And curve 2, you can see it was normal to start with, it is about 10. Then it has crossed a 10 centile line, and at 40 weeks, it is below 10 centile. So this is the typical IUGR and SGA baby. Okay, so all IUGR babies are not SGA. All SGA babies are not IUGR. Hope it is clear. So next question, what do you mean by stage 2 FGR? Stage 2 FGR. Answer. Stage 2 FGR. What staging is this actually? And I have used the term FGR instead of IUGR, fetal growth restriction. So what are we talking about here? Any answer? I think I have to answer this thing. So newer concepts are there. There is something called the Barcelona classification, Barcelona guidelines, where they have mentioned a new term like a FGR to replace IUGR, fetal growth restriction. And based on the Doppler abnormality and SGA status, they have classified it into different stages, stage 1, 2, 3, 4. I think I will just, sorry. I think because answer of other questions is also there, I will show the next after some time. Name the hypothesis that proposes the events during the early development have profound impact on one's risk for development of future adult disease. Yeah, FOAD, fetal origin of adulthood diseases. Yeah, that is what I'm talking about. Then the hypothesis is called Barker's hypothesis. Okay, fetal origin of adult diseases. So the implications during the fetal life, it will lead on to possible problems in the future. Name the clinical scoring of severity of intrauterine IUGR. Clinical Ponderal index is actually to differentiate whether it's symmetric or asymmetric IUGR. It is not a scoring, right? So what is the name of the scoring to find out the severity of malnutrition, in utero malnutrition? CAN score, yeah. It's called a clinical assessment of nutrition score or CAN score. So this is a staging. Stage 1 was the baby, if the baby is SGA, but and less than third centile with some Doppler changes like MCA, the reversal of the CPR ratio reversal. Then it is considered stage 1. Stage 2 means with the AEDF. Stage 3 means with the REDF. Stage 4 means there is a changes in the ductus venosus. So based on that, actually the timing of delivery, monitoring, everything will change based on the stage. We are actually following the Barcelona guidelines nowadays. And Barker hypothesis CAN score. Based on the severity of the wasting, score is given objectively. And based on that, we can assess the severity of malnutrition. Okay, going next question. So identify the condition here. One photo is given. Identify the condition. Imperforate anus. Okay. AR. That is a more comprehensive term. Anorectal malformation is there. Then, okay. So name the X-ray positioning done to evaluate. We have to evaluate further. So we have to take X-ray. So what is the name of that view? What is that name called? Like what is that positioning called? Invertogram is the old one where we actually we'll keep hold the means foot of the baby and we'll keep the baby head side upside down. That is called invertogram. We are not using it nowadays. Yeah, cross table lateral view. There is one more, one in between, one more word is there. It is called CTPL, cross table prone lateral view, CTPL. So here, what is the surgical procedure? We can actually differentiate based on the X-ray finding. We can see whether it is a low anomaly or it is a high anomaly. So if it is a low anomaly, then what is the usual surgical procedure done? Anoplasty. Okay. So more specific term is there. If you are able to tell the term, that will be better. I'll give you a few seconds. A. Okay. It is not A. It is P. PSARP is the term. Posterior sagittal anorectoplasty. It is not A. It is PSARP. And last question, the X-ray supine AP view was done for the baby. If you are able to appreciate, I will show in the next slide. If you can appreciate the findings in the next slide, just can you enumerate if any other additional findings are there? I'm not talking about the line CT tube and all, just other findings. Dextro, okay, it is a dextro pose. It is like a little bit rotated. It is not dextrocardia. Double bubble, yeah. There is double bubble sign here. Don't latricia possibly. Sacrilegenesis, it is okay. Actually, normal vertebral anomaly is correct. You can see there is some abnormality here. So hemivertebra was there in this area. So vertebral anomaly, anorectal malformation, GI anomaly. What can it be? Bacterial, a possible bacterial anomaly. So ARMC, TPL, PSARP, double bubble. You can see how cross table prone lateral view is taken. You can see the image here. You can see usually we will put a button or coin or something like that in the anal opening. And we will measure the distance between the gas shadow and the anal opening. If it is more than beyond certain, if I remember correctly, is 1 centimeter. If it is more than that point, then it is considered as high anomaly. If it is less, then it is considered as low anomaly. Hope it's clear. Next question. A mother brought 26 days old baby to the OPD with a complaint of persisting yellowish discoloration of the skin. Baby felt thriving, baby has gained weight properly, and mother has noted some abnormality in the color of the stool and urine. This happened actually. She brought with these two bottles with her. The first one is stool, second one is urine. So, can you name any 4 possible causes for this condition? What is the finding actually?
Neonatal cholestasis.
Yeah, this is a neonatal cholestasis. A pale colored, clay colored, Chinese clay colored stool and darker urine. It's usually cholestasis. So there are so many. Biliary atresia everyone has mentioned. Choledochal cyst is there. Then maybe 1 or 2 more. Pefic, okay. More common. Resisting jaundice with cholestasis. More common. Before Pefican and all, I think it's allegedly more common. We should rule out hypothyroidism. We should rule out urosepsis. All those things also to be ruled out actually. So on further evaluation, ultrasound abdomen was done and it showed a triangular cord sign. Now actually I think already neonatal hepatitis is also very important. So already diagnosis is EHB, extrahepatic biliary atresia, where ultrasound will show a triangular cord sign and HIDA scan shows absence of release of tracer into the intestine. So what is the gold standard? If it is biliary atresia, HIDA scan actually can be means we cannot use it as a confirmatory. If the tracer is there, we can use it to rule out EHBA. If it is not there, it is not 100% confirmatory. So what can we do? What is the gold standard test to confirm that? Intracolangiogram is the gold standard and biopsy. Both are gold standard. And the procedure is called Kasai procedure. Okay, correct. So this is the beautiful this table from not table, what do you call it? The flow chart from Nelson. Different hepatic and extrahepatic causes. Hepatic, hepatocyte related, bile duct related causes. Metabolic, viral, idiopathic, intrahepatic, Alagille syndrome, biliary atresia, all those. It's easy to remember also if you remember like this. Okay. So, simple question. A term male baby with a serum bilirubin level of 16 at 48 hours admitted for phototherapy. So what is we are using blue light, right? What is the spectrum of light used for phototherapy? Spectrum, that nanometer wavelength. What is the wavelength?
460 to 490 nanometer.
Yeah, correct. 460 to 490 is the blue-green spectrum is the best one. We are using blue spectrum. So mention 2 methods by which we can improve. How can you improve the efficacy? We are having a child, we are having a high value. What all things we can do?
LED lights.
LED light, yeah. Like we
Proper
can use
distancing.
proper distance, yeah. It has to be close, a new light, then distance already, yeah. That aluminum, that surface we can use, that reflective surface you can, double surface you can use. Instead of 3 lights from the top, we can use double surface phototherapy. The intensity of the light can be increased. All these things we can do. Then what is the expansion? So there is something called bind. It's a complication. So what is the expansion of bind? Bind, okay, whatever. Bind, the complication. What is the complication? What is the expansion? Sorry.
Bilirubin-induced neurological dysfunction.
Yeah, it's a bilirubin-induced. Carnivorous, previously we used that term, but it is like a more comprehensive term called bilirubin-induced neurological dysfunction. So what is the carnivorous is usually used for the chronic part, chronic encephalopathy part. So it is described as a tetrad of clinical features. So can someone explain What are the four components of kernicterus? A baby affected with high bilirubin later, what will happen to the baby? What all findings will be there? Gaze, what gaze? Gaze does not mean anything, right? Upward, low, downward, which area, which is restricted. Moro, what will happen tomorrow? I don't know. What, whether the baby will develop.
Cry.
Yeah, that is by scoring. Sorry, that is scoring, right? Cry, activity, and tone. I am not talking about that. I am talking about the tetrad, the four features of kernicterus, the chronic bilirubin encephalopathy. Yeah, upward gaze. Okay, then what else? There is one. Yeah, the dyskinetic CP, choreothetoid or dystonic CP. Then third, sensory neuronal hearing loss. Yeah, correct. Fourth, one more. Your voice is breaking actually. I'm not able to. Fourth one, fourth one. Yeah, dental enamel hypoplasia of the. Yeah, that's all. So four things are there. And there is a risk prediction. Yeah, dental enamel hypoplasia also will be. Okay. So what is the name of the risk prediction normogram? We are using AAP normogram or our what you call NICE guidelines normogram. Bhutani normogram. It is for the risk prediction, whether the baby will develop this thing in the future. So Bhutani normogram is there. For 60 to 400, the same way. Blue light area exposure, intensity, distance, number of units, aluminum foil, etc. So this kind of, okay, already discussed. Next question. So we can see one doctor is checking the baby using some instrument. So we are actually doing the eye screening for a preterm baby follow-up. So what is the gestational age and birth weight criteria for ROP screening of neonates as per RBSK guidelines? The basic guideline. What are the recommendations? Which all babies should be considered for ROP screening? Less than 32, 2 kg. 32 is not correct. RBSK, I am talking about RBSK guidelines. Yeah, less than 34 weeks, less than 2 kg. And if it is more than 34, should we do the screening? Is there any other extra points to be considered? Yeah, with the risk factors. Which all risk factors? A stomy newborn course. If any baby ventilated for 7 days, recurrent blood and RDS, all those, if the baby was sick during the NICU period, better to do a ROP screening. So can you enlist 4 risk factors for ROP in units? Development of ROP, sepsis, okay, preterm, IVH. IVH and ROP, is there any? I don't think so. IVH and ROP are different entities, right? Oxygen, yeah, oxygen, rather than oxygen therapy, oxygen fluctuation, high oxygen, high concentration oxygen, prolonged oxygen, fluctuation in oxygen. Jaundice and ROP, is there any correlation? Cardiovascular respiratory, so hemodynamic instability, okay, ventilate, all those things are there. Recurrent blood transfusions, IUGR baby, very important. Chronic lung disease, all those are okay. Then you can see that ophthalmologist here is using, there is a device on her head and she is using something in her hand. So what are those things? What is the name of the instrument called? To visualize the retina, peripheral retina. Direct ophthalmoscope. Sorry. Yeah, it is indirect ophthalmoscope. Indirect ophthalmoscope and condensing lens are used for ROP screening. So we have detected ROP. We have detected ROP which has to be treated. So we have got two options, either laser or anti-VEGF antibodies. So can you name two anti-VEGF antibodies used? Yeah, ranibizumab, bevacizumab. So bevacizumab and ranibizumab are used, and newer drugs are also available. Forgot the name. Okay, these are the most common. Yeah, aflibercept also there. Yeah, I forgot the name actually. Then these are the gestational age between late preterm babies with the risk factors also to be considered. Unstable clinical course, high risk to be considered. Indirect. Okay. Yeah. So most very common scenario here. The baby having the X-ray of the baby having two white lines in the X-ray. So what are those? Identify A and B. Which one is A? Which one is B? A UVC. Okay. Then definitely B will be UAC. Okay. So umbilical venous line and umbilical arterial line. So what is the formula for insertion? Which is you can just tell the formula you're using in your department. UAC, umbilical arterial line insertion. What is the formula used? Or the method used? You will be using the formula, right? Can someone tell me which method you're using
Shukla
in your
formula.
unit? Shukla formula. Okay. Can you can you define that? Can you describe?
3 into birth weight plus 9
Yeah.
by 2.
3 into birth weight plus 9 by 2 is actually for UVC. Okay. It is. I have asked for umbilical arterial line. It is 3x plus 9 plus umbilical stem length. So any other formulas or methods you know of other than Shukla formula? Can someone answer fast? I think our time is running fast. Other, I will just show in the next slide. Then, yeah, there is one. Then normogram is there. If you see the backward area of Cloherty in one page, there is a normogram given. So using the normogram, you can measure the length between anterior this and the shoulder and the umbilicus length, and you can use the normogram to measure that is called done. One more is that is called the Wright's method. I will show next. So what is the correct position? Whether it is in correct position, the B, is it in correct position? It looks like it is inside the heart, right? Should we pull that thing out? T8 to T9, T8 to T9, T10. Okay, high and low are there. So whether the line here in the X-ray is it in correct position? It looks like UVC is just outside the heart shadow, and UAC is deep into the heart. So should we pull it out? Or is it the correct position? Can someone answer? Yeah, it is in correct position. But why is that feeling like it is more inside the heart shadow? Is it inside the heart? So I will show that in the next. Yeah, it is in the aorta. Yeah, I will show in the next slide. And can you enumerate 4 complications associated with B? Umbilical arterial catheterization. Can you name 4? Thrombosis, thromboembolism, arrhythmias, okay, perforation, okay, bleeding, infection, all those things are there. Okay. So the formulas, there is Shukla formula, 3x plus 9 plus umbilical stem length. There is Wright's formula for preterm babies, 4x plus 7 plus umbilical stem length. And there is a Dunn method using a normogram. The normal position is T6 to T9. T6, it is not T8 sorry, it is T6 to T9. And T10, there is something called artery of Adam-Kiewicz, which supplies to the spinal cord. So we usually we don't go in that area. So T6 to T9 will be the correct. Low position is L3 to L5. And the complications he already mentioned. This is one image from Nelson. It's clearly, even though in the X-ray and your AP view X-ray, it shows very near. In the lateral view, it is very far away. Both the UAC and UVC are very in far away places. It is actually in the aorta. It has not reached the heart. And this is going near the heart. Okay. This image looks, it describes the UAC, UVC position in a beautiful manner. So this is the done method. You can see the anterior axle, the anterior shoulder too. This is the correct method to measure the distance between umbilicus and anterior shoulder. And this chart you would have seen. So that tip should be between these two lines. Okay. In this area. So length we have to measure like that and we have to insert. So coming to the next question, I think towards the end of our. So the antenatal ultrasound imaging is given. So there is one white line. So what is the measurement called? What is the marking? What is the significance of the marking? Yeah, it is CRL or crown rump length. So what is the significance? What is it used for? And what is the interpretation also? If it is some centimeter, what is interpretation? It is crown rump length, gestational age assessment, okay. And it is a gold standard for gestational age assessment. Okay, next, that if it is like 6 centimeter or 7 centimeter, what is the gestational age? So gestational age is the value CRL plus 6 centimeter, 6 weeks. So we have to add 6 to that. Okay. So what is the method of postnatal? The baby is born. So in the postnatal period, we are trying to assess the gestational age clinically. So what is that method called? And which is optimum time of assessment? The CRL is antenatal ultrasound method. And what is the clinical method in the postnatal period called? Yeah, this modified for new Ballard score. So what is optimal time? 24 hours? No. Initial 24 hours for preterm babies, extreme preterm babies. So they mentioned that we can do within 24 hours. That will be the best. Till 7 days is validated, but the optimum time is up to 96 hours, up to 4 days. So how will you assess the gestational age for? You are having, I will show the, I think this is the Ballard score. And you can see this is the score, minus 10, minus 5, 5, 5, 5, like that. It will go from minus 10 to 50. Based on that, we have assigned the gestational age, 20 weeks of gestational age to 44 weeks of gestational age. So if the score is like maybe 23, then what will be the gestational age? Is it 30, 31 or 32? 23 will be 30, 31 or 32 weeks of gestational age. How will you calculate that? I hope you understood the question. All these are like 10, 15, 20, 25, etc. is assigned a proper gestational age. So if the value, the score is in between 15 and 20 or 20 and 25, how will you assign whether it is 32, 33 or 34? I have arbitrarily, I have mentioned 23. 23 will come here between 20 and 25. So whether it is 32, 33 or 34 gestational age. Any answer? Can someone? I'll wait for a few seconds. After that, we'll. No answers. Okay, then I will. So actually, the first 3 values is assigned the first. Like if it values 20, 21, and 22, then it is assigned to 32 weeks of gestational age. Then 23 and 24 is assigned to 33. Sorry, here 23 and 24 is assigned to 33 weeks. and 25 is assigned to 34 weeks. I will show it in the next slide here. So this, if the value is between 25 to 30, the first 3 are assigned to the 34 weeks. Next 2 are assigned to the in-between gestational age, and the last one is assigned to the 36 weeks. Okay, hope it is clear. And one more question was there, right? So there are some situations where we'll be confused how to do the Bellard scoring. So if it is a breech delivery, baby will be having problems. You can see, you would have seen, right? Baby will be in the lower limbs, will be in abnormal posture. So how are you going to do the Bellard scoring here? What to do? Can someone talk? Or in a breech delivery, what can we do? Next, baby with no arms. Any 3 of the questions. If the baby is not having any arm, so how are you going to assign the Bellard score? And if the baby is ventilated, answer for any of these questions can. Shall I answer them?
Yes, Jathin, you answer that.
Okay. So for breech delivery, either we can actually wait for 48 hours. Hopefully it will improve and do the Bellard scoring properly. So if otherwise, what we can do is, we just the popliteal angle, those things you keep it like that, and assign score for the other parameters. And based on that, you assign the similar score for lower limb this thing also, parameters also. That is for breech delivery. If the baby is having no arms, then also you assign with using the other parameters and give a score as per the obtained parameters. For a ventilated newborn, it is not a contraindication to do Bellard scoring. It is, we are actually testing the passive tone. It is not the active tone. Okay. So unless the baby is paralyzed using a skeletal muscle relaxant or sedated deeply, we can actually do the Bellard scoring for ventilated babies also. Okay. Hope it is clear. I think, yeah. 27-week old male baby. The 27-week gestational age male baby developed respiratory distress soon after birth. Baby was started on CPAP support. So probably the diagnosis is RDS here. And when will you give surfactant? When means not the time. So timing also you can mention. I'm talking about the settings. Can someone answer? This is early, yeah, early rescue. Before 2 hours of life, we have to give. Then at what settings? The baby is on CPAP support. If the baby is on 21% FiO2 and a PEEP of 4 or 5, then will you give X-ray showing RDS is not an indication for surfactant. If the baby is clinically doing better, X-ray, we are not using X-ray for giving surfactant. 40%, okay. We are clean. Practically, we are actually not going that much. We are actually doing above 30% FiO2 at the PEEP of what PEEP? 4, 5, at 6 centimeter PEEP, if the FiO2 requirement is more than 30%, usually we use surfactant for that baby. X-ray will aid, actually, we are not depending solely on the X-ray. So what is the dose? You know the surfactant, it contains phospholipid and the proteins and all. So what is the dose of phospholipid? I'm not asking about the specific brand because phospholipid dose is the generic thing and the brand it will differ. 200 mg per kg. That is for poractant, 200 mg per kg. For the usual Sarvanda and all, it is 100 mg per kg. Sarvanda, you can see 4 ml vial you will be knowing. So 1 ml contains 25 mg. So usually the dose will be 4 ml per kg for that. 100 mg per kg of phospholipid. Poractant is 200 mg per kg. That is Curosurf. So name the method of surfactant. You can see one image taken from internet. What is this method called? of surfactant administration? LISA. Yeah, it is called less invasive surfactant administration, or LISA. Shall I ask one more? If you use laryngeal mask airway, then what is that method called? LMA to give surfactant. It's called salsa. Salsa, I think. Yeah. Lisa, I think all of you will be knowing. We are actually not intubating the baby with the ET tube. We are continuing the baby on bubble CPAP support, and we are using a thin catheter to introduce the surfactant. Okay. So that is found to be very superior in studies. The evidence like BP, every comorbidities, everything is less with the LISA. And okay, what is the dose of? Here, in order to prevent the RDS, we are giving corticosteroids for the mother. So, what is the dose of corticosteroid given to the mother? What is the GOA recommendation? What is the recommended steroid and dose as per the Government of India guidelines? Betamethasone 12 mg 2 days. Okay. And that person has mentioned betamethasone acetate. She knows the answer for not using betamethasone. Not using means GOA is recommending some other drug now. Dexamethasone 6 mg 4 doses. Yeah. The betamethasone which is available in India, it is betamethasone phosphate. Betnosol, betnosol, right? Yeah, betnosol is the betamethasone phosphate. So the betamethasone acetate mixture is actually a mixture. It is used in studies, so it is not available here. So Government of India recommends usage of dexamethasone, like 6 mg 12th hourly, 4 doses will be the other one was 12 mg 24 hourly, 2 doses. So within 2 days it has to be completed. So that is an anticorticosteroid. So the last part, just please tell the answers, okay? So few dermatological common benign conditions in few slides are there. So first one, second one, what are the answers? You can see, oh, I think I have used different pictures of the same condition. Later on, one more is coming. Erythema toxicum, it is actually not erythema toxicum. Cradle cap, it is cradle cap, yeah, okay. Milia, I think I will show some other better quality picture. The first one. The second one is cradle cap or seborrheic dermatitis. Next, you can see the baby is having something in the forearm. Something in the forearm. What is that? Yeah, someone has written neonatal pustular melanosis. The first one. This is actually pustular melanosis. You can see the pustules there. You can see black spots after healing of the pustules. So that is pustular melanosis. Suckling blisters, that's a correct answer. So it is because of the intrauterine suckling, the baby has developed these kind of lesions can be seen here, somewhere here. You can see. So that is suckling blisters.
Penile pearl.
Yeah, penile. What is that? Penile pearl. Yeah, it is Epstein pearl. Even though we usually see it is in the roof of the palate area, it can be seen in other areas like a penis, vagina, etc. So if you see a pearly thing at birth itself, it is usually Epstein pearl. Next.
Granuloma. Umbilical granuloma.
Yeah, it is umbilical granuloma. Can you tell me the common treatment modality used for that? Should we use any medication or use something else? Or do cauterization with surgery? Surgical, yeah, rock salt application. Copper sulfate. Salt is very effective in umbilical granuloma. Just apply some salt. After some time, it will reduce. So what is this other one? The swelling in the midline. divarication of rectal or rectal diastasis. Both are correct. Absent, it is a normal thing. It is not absent rectus abdominis. It is a normal divarication in between the rectal muscles. You can see a swelling sometimes. It is a normal thing. It will disappear after some time. Then they be having, usually Muslims are having a practice of shaving the head, right? 7 days, 14 days and all. So then it will become more prominent. You can see a red thing in the posterior aspect of the skull. So stork bite angioma, or what is the other name for that? Hello, someone has answered, I think.
Salman patch.
Yeah, salmon patch. Salmon patch or stork bite angioma. Then a baby having so many blackish things here, but it is in a pattern, like there is some.
Memory line.
Yeah, those are accessory nipples in the mammary line. Accessory nipples. It will be, multiple nipples can be there here in this line. Then what is this? This is what I was describing before. One more slide is there. This is also benign pustular melanosis. You can see pustules here. What will happen is after that, after some time, this pustule will be going out. And after that, you can see a lesion with the peripheral collar. It is also typical of, and after some time, it will become this kind of hyperpigmented areas, lesions. After some time, it will go away. So this is a typical benign pustular melanosis. What is the right one? Yeah, this is the thing which is usually diagnosed at birth and only antenatally or antenatal using ultrasound, or only at birth we will be able to identify this condition. So single umbilical artery, you can see one artery and one vein. Okay, so that concludes our today's session. I hope this just 1 hour only I have taken. See if any questions or any more explanation is required, and you can just ask if any of the
Please feel free
slides.
to ask for any clarifications if you have not understood any of it. It was a really good session. Anyone wants a clarification? FGR.
Thalamo-occipital distance. So usually there are three measurements are there we are using. One is the Levin's index. Sorry. One is the Levin's index. This one. One is the anterior horn width. Anterior horn width is this section. Anterior horn width, this area. And third one is the thalamo-occipital distance. There are two nuclei here. This first, the first one is a caudal nucleus, and next one is the thalamic nucleus. Okay. So from the thalamic nucleus, the posterior end of the thalamic nucleus, I am not using this part. I am not starting from here because this is the choroid plexus, which is hanging from the thalamic nucleus, in the posterior aspect of the thalamic nucleus. So I am not using, I am measuring the thalamo-occipital or the occipital horn. You can identify you are able to appreciate the ventricle here. The sagittal section of the lateral ventricle, a C-shaped thing here. In the C-shaped thing, this is the frontal horn. This is the occipital horn. So from the posterior aspect of the thalamic nucleus, if you measure until the occipital horn area, that distance will give something called thalamo-occipital distance, TOD. Using the thalamo-occipital distance, there is normogram based on gestational age, just like that of Levin's index. If it is beyond in the red area in that normogram, then also we can also use it as an additional information to manage the hydrocephalus. I hope it is clear. FGR graph, okay, that is also, I hope, basically it is the antenatal growth pattern graph. We are measuring the growth at different intervals. If we plot it in the Sendai line, 10th, 50th, and 90th centile. Some babies will grow. Normally, is actually probably these three are normal. This 90th centile, 50th centile, 10th centile are normal thing, growing as according to the centile. But you can see three lines which are growing differently. Curve one, what happens is it is actually starting and ending. It is between 10th and 90th centile. So it is not SJ as per definition. But if you see closely, there is a growth faltering happening during the intrauterine period. So that is the baby is actually IUGR. Intrauterine growth restriction has occurred. But the baby is AGA because the baby is more than 10 centile at birth. So this is IUGR, not SGA. Then the next line is this one, where it started initially about 10 centile. Then slowly, at the time of the birth, it has crossed the 10 centile line and it ended below 10 centile. So this baby, the intrauterine growth restriction has happened and finally it is below 10 centile. So it is IUGR and SGA. Here the third line, it is traveling along the centile line itself. Along the line itself, there is no growth faltering here. But throughout it is below 10 centile. So it is SGA baby, but it is not an IUGR baby. So these three are different from the normal. So I hope it is understood now. It's basically difference between IUGR and SGA. Any more questions? Baby with no arms, how to do? Yeah, that's what that was actually, the Ballard himself is actually telling that we have to assign other parameters. The arms means limbs, lower limb will be there. So the popliteal, all the other things we have to, the physical other parameters we have to see, the other neuromuscular parameters we have to see, and you will be having a rough idea that where the baby is standing. So you can assume the same score, the similar score for the arm parameters also, and count and calculate. Otherwise, what will happen if you keep it as 0? Then the gestation is going to come down drastically. We cannot do that, right? Any other questions?
I think that's all the clarifications they have asked. One more thing, when you mentioned, I think the grade of IVH and the
Yes.
staging, I think there was some confusion for some. But what sir asked was the grading of IVH is very different from the ventilator, the ventricular dilatation that has happened. So those are two different entities. For the grading of IVH, the dilatation has to happen acutely and not post. I think that's all, isn't it? Yeah. Thank you, Jathin. That was a really beautiful OSCE. I think interesting for them because I think for the postgraduates as well, all these things would be asked. Although I think there were a few bouncers for them where they were very quiet. Thank you. Yeah, and if you could forward the presentation to me, I'll put it as a PDF for them.
Yeah, sure, sir.
Thank you. Thank you again, Jathin, for that. Yeah.
Thank you.
Thank you, everyone. Good night. Good night.